epicondylitis because you said yes to the lateral epicondylitis tests, you know, because you showed me the radial tunnel spot over and over. So definitely show and tell on, so this brings us to cranialism number 4. Provocative tests are not yes/no questions. And I think sometimes with physicians they are. I think many times with these couple of, you know, handful of provocative tests that the physicians know, they just say, does that hurt? And, you know, again, I don't think it would be so dramatic that, you know, you do the tennis elbow test and your left earlobe hurts, but you never know. Certainly you do the tennis elbow test and your radial tunnel spot might hurt more. Okay. So, I really spent a lot of time trying to figure out for myself how to really get the best information from my clients on pain, numbness, and tingling. And so for me, it makes a huge difference. You really want to differentiate the sharp, eye bugging, hair on fire, you know, pain, which is your tendonitis pain, from your dull, achy pain that tends to be more chronic and lingering, okay? And so I asked them separate, and you know, I mean, at our facility, just like every place else, they want that 0 to 10 number for pain. To me, sharp pain's 10 of 10. And you know, your 10 may actually be a 20, but you know, it's sharp, you know, your eyes are gonna bug, or you're gonna jump, or you know, gasp or something. But it's just a second, right? Okay? And so, that versus your achy pain, and I've really kind of laid out how I want my patients to tell me about achy pain, because you know, like sometimes they'll say their pain was a 2 or a 3, and it's like, look here, dude, nobody navigates this healthcare system to come in for a 2 or a 3 pain. You know, it had, you know, 2 or 3 pain you can easily ignore. You know, by the time you hit the age of 40, you ignore 2 or 3 pain every day. You know, that is your new 0. You know, so I really go through this whole pain thing, and I have an article on that, and so there's a link on that too, but kind of how I have found to kind of take my patients through the whole pain thing. The other piece is how to listen to your body, you know, because we, Tech Sergeant Middendorf, another Air Force colleague, retired, she started this whole car analogy, and then I just loved it and kind of took off with it. So part of it is stolen from her, but you know, it's personalized for me now. We use the car analogy in our ergo class. And so, you know, I say that I'm still driving my most favorite car I ever had. You know, I take great care of this car. You know, when, especially, you know, I mean, now it's like 14 years old and it's hard to get it worked on and all that. But, you know, a few years ago, we're driving down the car, you know, I mean, we're in the car, and we're chit-chatting, you know, we're driving along, and I hear a rattle, and I'm like, shh, 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 you know, I'm rolling down the window, did you hear that? You know, got my mechanic on speed dial, you know. I know the names of his daughters and his dogs and, you know, the whole bit. I take good care of the car. And I turn the radio off to listen to the rattles. But what do? When we hear rattles in our body, crank the radio up, right? Okay? So you kind of have to help your patients learn how to crank the radio down, because this should be another cranialism, I left this out. Nobody falls apart overnight. How many times do you have a patient, because patients tell me this all the time, I just feel like when I hit 40, I just fell apart overnight. You didn't fall apart overnight, you just couldn't get that radio any louder. Okay, so really differentiating your sharp pain, your achy pain, and really, we keep throwing this together, numbness and tingling, but those are really, really, really quite different as well, yes? Numbness and tingling are totally different. Okay, so average daily pain, numbness, tingling, the whole bit. Frequency, duration, and intensity. Because here's kind of this funny thing patients do. If they're having the achy pain and the sharp pain, somehow they kind of like average those numbers together. You know, so they'll come up with a number of like 4 or 5 or something. More handouts? Yeah. Raise your hands if you're missing handouts. Looks like she's got 2 different stacks. So, okay, where was I? Average. Yeah, they kind of like average it together, you know, because that sharp pain just lasted a couple of seconds, you know, and so they kind of minimize that. And so you really need to, you know, and do the whole dramatics, you know, I mean, is this like sharp here? You know, and really dig it out of them. And then, you know, we ask the typical things, you know, your symptoms at rest. Because, again, with your arthritis patients, you know, the first thing in the morning and the end of the day, those are kind of the big times. Versus these clients, it may be really bad all day, but a lot of times it's not so bad, and then as the day progresses, it gets worse. And then by the time they finish their day job and they get home to their family, and it should be mid-time now, you know, they're really hot with pain. So these are my articles. treat your body like your favorite car, and how to talk to your doctor about pain. Okay, so this again, tennis elbow, DeQuervains, really sharp pain. So, and this is one of the very, very, very few times, like with tennis elbow or DeQuervains, that I really do kind of catch patient off guard. Usually I don't. Somebody stand up, like on this front row real quick, and let me use your wrist. Okay. So I'm usually not mean, but I say, can you tuck your thumb? Well, if you're seeing that they're having difficulty tucking their thumb, you don't really need to do that Finkelstein's maneuver. And I might say, is this, and you're like already kind of backing off, so this is like really tender to touch, and you say, yeah. And I say, so if you move your hand like this, is it going to be like really painful? And you say, yeah. And I'm like sharp painful, like your hair's on fire, and they say, yes, okay, let's do Finkelstein's. But otherwise, if we're kind of questioning, you say, okay, let go, let me move it. Okay, you see that? Nice and easy, and then wham. Okay, but I mean, really, I really try not to unless I really have to. Okay, until next time. So the tendonitis, the DeQuervains, the tennis elbow, it is like sharp, sucking your breath, hair on fire, sharp pain. If they say, yeah, that kind of hurts, then it's not carpal tunnel or DeQuervains. The other thing you have to ask them, and it's in my template for my eval, because you'd be surprised how many people won't tell you that they had a steroid shot. Okay, so you really do need, so if they had the steroid shot, that might make a huge difference, and they might be all lovely again, and continue doing the stuff that got them in this mess in the first place, and then that's when they come in and say, it was great for 6 weeks, and then it was like it was worse for. Yeah. Okay. I think I need to set this up, my voice is going. Okay, so we've kind of gone over all this, yes? Okay, then we're going to skip through all the, okay. So we talked about this too. So with the, I usually hear sharp pain from carpal tunnel, but you do hear sharp pain complaints from the cubital tunnel folks, but it's different from the tennis elbow, right? I mean, they might say it's like a jolt or an electricity. Or some people will tell you it's like a nerve pain. I mean, some people, myself included, unfortunately, we really have experienced, joint achy pain, muscle soreness pain, and nerve pain. So some people will say it's really like a nerve pain or like an electric jolt. We're talking about the nerve stressing as opposed to nerve gliding, right? Everybody straight on that? Okay, so what we were taught for nerve gliding is a provocative test. Feel free to use it as such, but that is not therapeutic activity. Okay, these are for you. Okay, so this is part of, my bias on what really is and is not lateral epicondylitis and cubital tunnel and DeQuervains. Okay. So these things well enough that you decided, okay, this is not, DeQuervains, or this is. Now I have to tell you that with this, frequently you will have a textbook classic Finkelstein's for DeQuervains and textbook classic findings for tennis elbow. But they may tell you, that it comes and goes, or actually I kind of go more on the activities, which I think there's a slide coming up on that. If it's the cubital tunnel, one of the things that I found is you do this nerve gliding, provocative test, and it's negative, which I should have figured out before I did, because I was having that C6 dermatome. I get sharp pain at my wrist here, and I thought I was so smart because I knew it came and went, and so it wasn't DeQuervains, so I thought, oh, it's the dorsal radial sensory nerve. But it was my levator, because one day I had a really sharp pain in my neck and my wrist at exactly the same time. It was like this whole big eureka thing. Where was I going with this? Oh well, I've told you plenty of other great stuff, so. Okay, oh, it had to do with, oh yeah, the testing, yeah, like I had C6 and C8 symptoms. So I had C6 symptoms on my right and C8, like achy cubital tunnel pain on the left. And as I would demonstrate these nerve gliding exercises, it's like, well, mine I have to kind of like cheat a little bit and do it this way, which should have told me, you know, that, okay, well, if you have to cheat and, you know, bastardize the ulnar nerve thing to get your ulnar nerve pain, well, then maybe it's not ulnar nerve. Okay, so to kind of go then away from your distal diagnosis and towards your proximal etiology, one of the things you might identify that there's a lot of forward posturing. So they may or may not also have, you know, some of this postural, positional, thoracic outlet stuff going on. But if you're doing a lot of forward posturing, so you're shortening these muscles, and then what's happening to these? Stretching or overstretching. Okay. And then another thing that happens is part of the history is extensive time looking down. Okay, so you can get that computer monitor right. You know, we can put a couple of books under the computer monitor and we can get that right. But unfortunately, a lot of us, all those hours we spend at the desk, a lot of it's not really actually working at the computer and the monitor. It's reading and writing on the desktop. Yes? Okay, so we're looking down. So if the levator attaches to, like, close to the superior angle, that medial angle of the scapula, and kind of at the base of the skull, and you're looking down, is it in a shortened or lengthened position? It's in a lengthened position, but is it active? Is it working?
No.
Is it active? Is it working?
Yes.
Yes, it is. Your shoulder stabilization muscles and your scapular stabilization muscles, unless you had a stroke, unless you're comatose, unless you're totally knocked out, they are always on duty. Stabilizing, right? Okay, so they are working. But that's not the natural way of things, because most of our extremity muscles, they cross a joint and they either bend or straighten something, and they do that by shortening or contracting. So this is kind of an unusual situation. So it's no wonder that those muscles kind of tend to get knotted up. The other thing that so laptop, so there's no way to use a laptop ergonomically without a docking station. If your eyes are supposed to hit the top third of the screen, and I'm telling you, open up your elbow angle from 90, and it's really hard to open up your elbow from 90 too much, okay? So there's no way to use a laptop ergonomically without a docking station, and that's, I don't think I need to say anything else. That. The other one is new moms and dads nursing a baby or feeding a baby, looking down, and one of my PT colleagues turned me on to this. Major Charlie told me about that one. And actually, the new moms come in with DeQuervains. And it's not DeQuervains, it's the levator from looking down at that beautiful gift they got. Okay, so here's the